The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everyone, and thank you for joining us for tonight's webinar, Transplantation, Getting to Know Your Transplant Center. I am Nicole Haar, Director of Community Engagement at the PKD Foundation. Also joining me tonight is Geraldina Ferenzi, our Community Outreach Coordinator. We will both be with you throughout the evening, so if you have any questions, you can send us a message via your chat box. We are recording this webinar and will archive the recording on our website within the next few days. Please note that the PKD Foundation does not offer medical advice, and the information shared this evening is not intended to be a substitute for consultations with your health professionals. Care and treatment decisions related to your health must be made in consultation with your health professional team. We did receive some questions ahead of the webinar, and these questions have been shared with our presenter. We will do our best to address any questions you may have throughout the presentation at the end of the webinar. All attendees will remain muted throughout the presentation to ensure good audio for everyone. Please type your questions into the question box located in your control panel on the right side of your screen. Geraldina and I will be watching your questions and comments come in, and we will address them at the end of the presentation. Our speaker tonight is Melissa Blevins Bein. Melissa is a transplant administrator at University of California at Davis and became involved in organ donation 20 years ago as an RN transplant nurse coordinator for liver, kidney, and pancreas transplant programs at University of Kentucky. Since then, Melissa has held leadership roles in multi-organ transplant centers, including Mayo Clinic in Arizona. Passionate about organ donation and transplantation, Melissa decided in 2010 to walk the talk by putting herself through her own program at Mayo Clinic as a living kidney donor. She donated a kidney in 2010 to friend Risa Simon, who suffered from PKD. They celebrated their 8th kidneyversary this summer and are both doing fabulous. Melissa is a native of the Southeast and currently resides in Sacramento, California, with her husband Ron, mother-in-law Anna, and dog Scruffs. Melissa, thank you so much for being here with us tonight. And I am going to turn this over to you. Just give me 1 second so that you can run the presentation. Okay, it's coming your way.
Okay. Thank you, Nicole. Can you see what I'm seeing?
Yes, we can see your slide.
Lead slide. Okay. And that's me. And you just heard my introduction. So thank you, Nicole. I'm thrilled to be able to give this webinar. Transplant is something I'm very passionate about, and I love seeing people get transplanted and bouncing back. That's just been, I feel really lucky that I've been able to witness that in my career. So what we're going to talk about today are, I'm going to explain the tests that make up the transplant evaluation. We're going to talk about the requirements for donors, and we're going to describe the factors to consider when you're choosing a transplant center. But I hope the real value comes in what I call the MB tips, which are bolded, and it's information that's not necessarily written down anywhere, what I refer to as the informal knowledge. So I'm thinking and hoping that that's going to be the most value for you. These are the questions that I get asked by family members, friends of friends, when they reach out about how to navigate. How am I qualified to speak about this topic? Well, you already heard. I'm a registered nurse. I was the transplant nurse coordinator. I was a transplant administrator for Mayo Clinic and now at UC Davis, and I'm a living kidney donor. So I've been on all sides of this. Here is a fabulous picture of me. I'm on the left, and that is Risa Simon, my recipient. And our surgeries took place in June of 2010, and I'm really happy to report that we are both doing great. It's been a gift that keeps on giving, living donation, because Risa has gone on to do some really incredible things for patient advocacy, and it just fills me up with feel good. A quick disclaimer, views expressed here are mine and do not necessarily represent those of my employer, University of California, Davis. So this is the big picture. These are the 5 stages of transplant. The size of the bars is not in correlation to the time. We'll be going over all these in greater detail, but I thought it would be helpful to see the big picture first. The phases are the same in every transplant center. So let's start with the first stage, referral. This is where the transplant journey begins. And a referral is made by a general nephrologist, primary care physician, really any physician's office. But you can also self-refer, and I highly recommend it. Information that is collected at the time of referral, I have listed on 2 slides, this one and the next one. And it includes name, address, date of birth, contact information, and the stage of chronic kidney disease, or CKD, that you are currently in. Most recent labs, your GFR and creatinine, current height and weight, and this happens to be the one that is most often missing in referrals. And if you are currently on dialysis, and if yes, is it hemo or peritoneal, and the exact date dialysis began. That's a really important detail, and it has to be an exact date that dialysis began. It becomes important if you go on the list for a deceased donor, and it has to do with, it's one of the calculations that they input, UNOS. A history and physical is the note that the doctor writes every time he sees you. It's referred to as an HNP. So those are all of the items to collect. And if you're going to self-refer, these are the items that you will need or that will be asked of you. After all the information is received, and medical records are reviewed by the transplant RN coordinator. And the RN coordinator is looking for anything that falls outside of acceptance criteria. So the first question is anything that falls out of acceptance criteria. And then the second question is, if yes, are these things that can be changed? So examples of things that can be changed are weight, compliance with medical treatment, drug use and abuse, and availability of a caregiver. Things that cannot be changed are age or severity of cardiovascular disease. For things that can be changed, the RN coordinator usually reaches out to the patient and says, you know, you need to get your weight down, or, you know, addresses whatever the factor is that can be changed. And then they can proceed with the evaluation once that is addressed. Timing is everything. The sooner you are educated and referred, the better. Assume that all transplant centers accept self-referrals, and don't hesitate to make the call. Call the main number of the hospital and ask to be connected to the kidney transplant program. But don't hesitate to make that call. And then get and stay organized. Find a way that works for you. You will be receiving a lot of information in the form of paper. You'll be getting things in the mail and patient education materials. So it's good to start off organized and a way that works for you. So now we're to the second phase, and that's evaluation. And here is where the transplant financial coordinator plays a big role. There are 4 things a transplant financial coordinator is responsible for addressing, and this has to do with insurance authorization, especially if you are covered by a private payer. So the first component is, can this patient be evaluated at this transplant center? That's a completely different authorization than the actual transplant event. So that's the first question. And then if the patient is allowed to be evaluated at this transplant center, can they be listed? And if there's any testing required while waiting, that's another authorization. The transplant procedure and inpatient stay, they obtain authorization for that event and the associated costs. The medication coverage is the fourth component, including how much post-transplant medications are expected to cost post-transplant. This is one I get a lot of questions about. Nothing should be a surprise post-transplant. The cost of medications should not be new information. For the transplant center, the worst case scenario is that an organ is transplanted and the person does not have the means to care for it. Now, there are situations where, a patient's situation changes and that happens. And when that does happen, so there was a certain, situation that was, there was a plan in place, there was money saved before transplant when they were listed, but something has happened between that time and the time that the patient is transplanted. And those things do occur. And in those cases, the social worker has access to programs through pharmaceutical companies for unanticipated circumstances. But at this transplant center, for instance, there's a worksheet that is completed. And it's shocking to patients. I know I've gotten feedback about, that was brutal, but we would much rather the patient have that information before the transplant and really have that information up front so they can make informed decisions about their care. So this is something that there were several questions on, and we can talk more about it in the questions and answers. The members of the transplant team, there are many of them. This slide is really to represent that the transplant RN coordinator is the hub. That is usually the primary contact. I don't know of any transplant centers that operate in any different way. The transplant RN coordinator is the hub and the center of the transplant experience. These are the tests and appointments. Ultrasound of the abdomen, blood tests, they'll take a lot of tubes, urine tests, creatinine, chest x-ray, ABO, it's blood typing, and tissue typing. And there are many different healthcare professionals involved in the transplant process. We talked about the transplant RN coordinator. The transplant surgeon is the one who performs the surgical procedure. The transplant nephrologist is the kidney doctor, and he or she does the evaluation prior to transplant and also manages immunosuppression, medication, and medical issues post-transplant. The financial services representative, they're called different things at different centers. I refer to them, I did in the previous slide, as the transplant financial coordinators. But these are the people who obtain the authorizations that I talked about in the previous slide. Transplant social worker ensures adequate caregiver support, helps with lodging, and also with FMLA paperwork. The transplant dietitian assists patients with special diets. And the transplant pharmacist is a pharmacist who has additional training in transplant immunosuppressant medications and drug interactions. The transplant evaluation lasts 2 to 5 days in an outpatient setting with test appointments, education, and labs. Education is an important part of the transplant evaluation. There's education about the types of kidney transplants, examples like living donor, the option of paired kidney donation, and deceased donor, and education about the categories of deceased donors, high-risk donors, and increased risk. And this is new. The designation of increased risk was just designated in July of 2017. And I have more information on that in a subsequent slide. But these are important because you make a decision about the ones that you would consider accepting at this time. So it's really, you know, the more you've had time to think about it, the better. So these are some MB tips. Bring your caregiver to transplant evaluation. It's so important that many centers are making this a requirement. The caregiver is vital to the success of the transplant. Bring 2 notebooks and 2 pens to every appointment, one for you and one for your caregiver. And throughout the evaluation, record as much as possible. And this is really for 2 reasons. We as humans are much more likely to remember things that are written in our own handwriting. And then there's the, you know, that burning question, you know you will remember because it's so important. Well, studies show we don't remember. So please write it down. That goes for you and your caregiver. Write it down. Bring snacks and drinks in a small insulated cooler. The pace can be quick. The appointments can be back to back. And I don't know if you've heard of the term hangry, which is hungry and angry, which I am suspect to getting. So this prevents against that. But of course, a larger issue is blood sugar levels. So bring snacks and drinks. And lodging. Check to see if overnight lodging is available for patients going through transplant evaluations. Oftentimes, the lodging options are prioritized, and so post-transplant patients get priority, but you never know. So check to see if overnight lodging is available, especially if you have a late day appointment and an early the next morning. So now we're in the 3rd phase, wait list. So getting to the wait list, there are 3 steps. The selection conference, approval to be added to the UNOS wait list, and living donor, the question, living donor or deceased donor. The selection conference is there are a lot of words used, but really the core question that's being asked is this: does the risk of transplantation, the surgery, outweigh the benefit for this patient at this time? And so there are a lot of words said around that, but this is really the essence of what is being, what they're trying to get at. All the lab and test results from the transplant evaluation are compiled and they're presented at selection conference. And selection is a weekly meeting of all the healthcare professionals that make up the multidisciplinary team. It includes all of the people we talked about on that previous slide, including surgeons, transplant nephrologists, the RN coordinator, social worker, registered dietitian, pharmacist. The decision is collaborative, but everyone has a voice. And sometimes these are highly spirited conversations. After patients are approved to be on the waiting list, the next question is, does this patient have any living donor options? So living donor versus deceased donor. Living donor is a planned event scheduled as soon as you and your donor are approved by the selection committee. And this is my note, this is your best option. Deceased donor is not a bad option, but living donor is the best. Deceased donor is an unplanned event. It's dependent on blood type and presence of antibodies, and the wait for a kidney could be several years. And this is the phase that I call hurry up and wait, because there's a flurry of activity to get the evaluation complete, and then the patient gets listed, and then it's like, okay, now what? We wait for a kidney. What is the best case scenario? Living donor transplant before the need for dialysis, especially for PKD patients. So wherever you are in the process, this is the best case scenario. It doesn't mean it's the only case scenario. So what are the criteria to be a living kidney donor? A person must be 18. They must be in good health. They must be free of infection, which is hepatitis C and HIV, free of cancer, uncontrolled high blood pressure, diabetes, heart disease, liver or lung disease. They cannot be obese and they cannot be pregnant. The main takeaway here is that it must be voluntary. So throughout the donor evaluation, questions are asked by each healthcare professional. And they're framed in a lot of different ways, but all are getting at the same question. And that's, are you here voluntarily? Are you being coerced in any way? And that's code for, are you being paid? You know, has someone made an offer of money for you to donate your kidney? So it'll be framed a lot of different ways, but they're all getting at the same question. Are you here voluntarily? Let's talk a minute about multiple listings. So getting on the list at more than one center, is that allowed? Yes. It's called multiple listing. It's completely acceptable for patients to be considered for organs that become available in other areas. Now, they must be evaluated, patients must be evaluated and listed at each center, because each center has slightly different criteria for acceptance. And here's a little tip. Obtain copies of all your medical records, all those tests that we talked about, obtain copies of all of those. And that way it will be easier to take to a different center to get listed. You know, they won't have to start all over. There will be some tests that they may some centers want certain imaging, for instance, done at their center. But for the most part, everything, most of the information should translate. Is there a benefit to multiple listing? Yes. And the best example that I can give you is here in California. And I think it probably represents the most extreme example. But one of the reasons that UC Davis has been so successful, for those of you who are unfamiliar with the area, Sacramento is about 90 miles directly east of San Francisco Bay Area. And so it would make sense that people get listed at one and at the other, meaning one in the Bay Area and one in Sacramento. We're the only one in Sacramento. Now the difference is if you get listed at UCSF, which is in San Francisco, which is part of the UC system, the wait is 8 to 10 years. Now, I don't know about you, but a lot could happen in 8 to 10 years. And physical status can change. You know, it's a really dismal wait time for the Bay Area. So patients come to us to get dual listed, and they get dual listed here and they get transplanted within 3 years. So that demonstrates the value of multiple listing. Now it's highly dependent on where you are, and hopefully no one has to wait, 10 years for an organ, but that is the reality in that area. The same is true in Los Angeles. So there is a benefit to multiple listing. In some places, the benefit is extreme, and I think this represents probably the most extreme here in California. How transplant centers are alike. There are a lot of rules issued by the federal government, and they're all intended to protect, the United States public, and also to ensure equity in organ allocation. So the two arms are United Network of Organ Sharing, which the acronym UNOS, you'll hear that used, and then CMS, the Centers for Medicaid and Medicare Services. Medicare is the largest purchaser, if you will, of kidney transplant services. So they have a vested interest in two ways. One is their mission is to protect the health of the public, but the other piece is we're getting a lot of their money. We meaning the transplant community. So they're duly motivated to regulate. The rules for transplant centers are very specific. So an example is a letter must go to the patient within 10 days, and it must have this on it, and it must be dated. The parameters are very tight. So the result is there's a degree of similarity among all transplant centers in the United States. That's why we know that there are 5 phases in every single transplant center. But there are examples of how transplant centers are different. So I'm going to talk about pre-transplant, transplant, and then post-transplant. So pre-transplant, the listing criteria. So variations in age criteria. 60 used to be the upper limit of what was considered safe to transplant. Now it's 75, so I guess that makes 75 the new 60. And I've even known of one recipient who was 83. Now that was an extreme, situation, but you can see where just in my career over the last 20 years, 60 used to be considered way old, and now we do those routinely. Conservative transplant centers have a lower age limit. Aggressive transplant centers have a higher age limit. And it's important to understand that neither is good or bad. It just comes down to what the surgeons are comfortable with. Then there's the variations in amount of risk that the center, the surgeons, the program is willing to take when it comes to high risk and increased risk. And stay with me here. This is a little dense, but it's important. The U.S. Public Health Service publishes guidelines for reducing transmission of HIV, Hep C, and Hep B during organ transplant. It's intended to identify those donors who are most at risk for having a recent infection. The high risk historically has meant high risk behaviors like IV drug abuse. In July of 2017, there's a new category called increased risk. And it's specifically for donors who've been declared brain dead as a result of the opioid epidemic. The opioid epidemic has had a real impact on the organ donation community. And statistically, there are at minimum 10 people actually listening to this webinar who have been impacted or are currently impacted, meaning someone they know and love is addicted or has already succumbed to drug addiction related to opioids. It's a national crisis. The number of potential deceased donors classified as increased risk has increased to almost 1 in 5 donors nationally. Now, there's always been a percentage of donors that were as a result of drug overdose, but 1 in 5 is staggering. Why is this important? Many viable organs were not being used because they were being labeled as high risk, when there may not have been any needle IV drug use at all. An example is an overdose on OxyContin. In addition, the diseases that the Public Health Services was trying to protect the public from are now treatable. Hepatitis C is now a treatable condition, and HIV is now classified as a chronic disease. We are even transplanting hepatitis C positive organs, we meaning the transplant community. We're transplanting Hep C positive organs into people and then treating those patients after transplant for Hep C, and successfully. So transplant teams are in varying stages of accepting this new practice, and that's one of the ways that transplant centers are very different. I like to think of it as the early adopters, and then and we're right in the phase of there's always going to be the early adopters, and there are centers who are willing to take this risk But there are also centers who are not. Other examples of how transplant centers are different. The surgery itself, and this is specifically for PKD patients. Some centers will perform native nephrectomies at the same time of the transplant for living donor cases only, but some will not. I've seen this more recently used as a, I don't want to say marketing tool, but definitely they've gotten the message that this is something that patients want. They want economy of effort. You know, I want one surgery, not two, and it makes total sense. So this is another thing that transplant centers are very different about. They have different philosophies. And then post-transplant, there's medication management differences. The best example is steroid avoidance. Some people are very motivated to avoid steroids at all costs. And in addition to that, the routine kidney biopsies as part of protocol. Some centers have performed routine kidney biopsies not as needed, but as part of a protocol because they're collecting data and it's part of a research project. So it's important to understand, you know, what their philosophy is, and if steroid avoidance is something that's important to you, routine kidney biopsies are not fun, and it can be a deal breaker for some patients. The other thing that's different is the requirement to stay local after transplant. I've seen this range from 2 weeks to 6 weeks. And so it just depends on the philosophy of the transplant center. So there's some variation there as well. Choosing a transplant center. There are 258 transplant centers in the United States, and all of them must follow those strict professional and regulatory standards that we talked about before. It's important to keep in mind the context. So the difference between the best and worst transplant center in the United States is 3%. That's really small. And if a transplant center falls below 91% survival rate, if they fall below that, they get shut down. So in that way, the United States is a good place to be. There are a lot of drivers protecting the public from any kind of transplant center that gets outside the lines. Going rogue is what we call it. Geographic proximity is often the biggest factor in choosing a transplant center, and that is just a practical consideration.
Thank you.
Transplantmodels.com. This is a tool published by Johns Hopkins to help answer the important questions. It's free, and you can access the information as easy as your doctors can. I'm a fan of this. I'm a fan of anything that patients can get their hands on and have access to that helps them become more informed and more empowered to make informed decisions. So I know one of the people who was involved in developing this, and he is a statistician and a physician, and he is crazy smart. And I'm not surprised at all that he came up with something this awesome. So there are several different calculators on this site, but what it does is it predicts the chance of survival for one alternative over the other. So an example is, should I accept a PHS high-risk kidney? The actual question is, what is the chance of survival if I accept a high-risk donor kidney versus staying on dialysis and waiting for another offer? Knowing the question is a really powerful and important first step in assessing transplant centers and which steps to take. understand the question. What is my chance of survival on dialysis versus my chance of survival receiving a kidney transplant? Now, you'll notice the similarity to that core question, the essence of that question that is being asked at selection conference. This is really back to that. And so what this group has done, what Johns Hopkins has done, is you can enter, your information, and it'll give you, your chance of survival on dialysis versus your chance of survival receiving a kidney transplant. That is powerful information. Both come with risks, and what is not fully appreciated is dialysis is not risk-free. Health erodes in direct correlation to how long a person is on dialysis. And what I get the sense that there's a misperception that dialysis is just like putting a pin in it and pushing hold or pushing pause. It's not. So there are risks with getting a transplant. There are risks for staying on dialysis. But this is a tool that will help you sort through that for your specific situation. Waiting for transplant. If you're waiting for a deceased donor transplant, things to do now so you won't have to later. We talked about the importance of getting and staying organized, and it's in here several times because it's that important. Keep a binder of your records, your medical records, to help you manage information, medical and financial. Caregiver, caregiver, caregiver. This has also come up, I think this is the third time, and that's because it's that important. The caregiver needs to be someone who has the time, the health, and the flexibility to be your caregiver, and choose wisely. This is a very often overlooked but very important detail. And it's become so important that some centers, like I said, have required that the caregiver come with the patient to the evaluation so that they can hear the same things that the patient is hearing. Prepare a phone and email tree to make it easy for the caregiver to provide updates. And just make sure that your personal affairs, that somebody else can get access to your bank accounts, that they know where the advance directives are, they have the password to your email. If they're doing a blog updating friends and family, that location is known, passwords are known. FMLA paperwork, insurance, and or student loan deferment paperwork. All of these are things that you shouldn't have to be worrying about when you're in the hospital. Arrange for travel when you receive the call, and arrange for lodging if you're traveling from out of town. Waiting for transplant, prepare practically. Take care of yourself. The better your health at the time of transplant, the better your recovery will be after surgery. And that's another one that I could repeat 3 times. Really, really important. The better your health at the time of transplant, the better your recovery will be after surgery. So focus on a healthy diet, exercise, all the things that we're always told to do and, do and don't follow, and relaxation to the extent that you're able. Continue to get medical care while you are waiting, and that's with your primary doctor, either your referring physician or your nephrologist. Once a year, while waiting, you go to the transplant center, and just to make sure that that your health status hasn't changed significantly. And keep the transplant team informed of any changes in your health or changes in insurance. Major, major, major details. And keep contact information up to date. Make sure we can get in touch with you when we do have an organ offer. I have actually not been able to get in touch with patients when they had an organ offer, and it's so frustrating. This is what to pack: clothing that fits loosely, sleepwear, eyeglasses, readers, hearing aids, all medications, personal items like music, magazines, books, photos of family and friends, And then change the packed items seasonally as needed. Include any monitoring equipment, blood pressure cuff, sleep apnea equipment, thermometer, glucometer, and a scale. And decide what to pack. Pack as much as you can ahead of time. And then make a list of what to add when you receive the call and just lay it on top. That way, because when you get the call, you're going to be scattered. And I would not expect anyone to remember what they need to add to the suitcase at that point. So stage 4 is the actual transplant. So the actual transplant, the patient goes under general anesthesia. The kidney is transplanted in the lower abdomen, and the blood vessels of the new kidney are joined to the existing vessels in the groin area. With PKD patients, native kidneys are not usually removed during transplant surgery. However, more centers are offering it as an option for living donor cases only. Post-transplant, expect to be in the hospital for 2 to 4 days, and then you'll be discharged. And this is the variable that we talked about earlier. Some centers say you have to stay close for 2 weeks, 3 weeks, 6 weeks. I've seen all different kinds. So it also depends on how your surgery went and how stable you are after transplant. So there are a lot of variables that go into that, but each transplant center has a different philosophy. Is there a hospitality village if you do have to stay for up to 6 weeks? Are there special arrangements with local hotels? And then outpatient, you will get frequent labs at first to regulate the immunosuppression meds, but that decreases in frequency over time. These are the online resources, and a copy of this presentation will be posted on the PKD website. Transplant Models is the one we discussed about how you can enter your own information and assess risk. TransplantLiving.org is a website that's from the National Donate Life America organization, and it's really all types of topics on living with transplant, both prior and after. UNOS, UNOS is United Network for Organ Sharing.org, is the brains of the organ allocation system. It's located in Richmond, Virginia, and they have an up to the minute tally of how many people are waiting for an organ at any given time, 24/7. And then SRTR is the Scientific Registry for Transplant Recipients. Now, this is if you love statistics, you will love this website. It is dense. And so for those that really, like to talk about statistical theories and such, this is a very, helpful and informative website. It's not for everyone, and it's dense, and I warned you. So that concludes my presentation. My contact information is included here. Feel free to email me. I'm available, and if I can answer questions, I certainly will.
Thank you, Melissa. That was wonderful. Such good information. I'm going to leave the presentation with you just in case you need to run back to any of your slides. So I won't take it back at this time. I'm pretty confident that you've answered quite a few of our questions tonight already, but we do have quite a few to get to. So we'll start taking those in just a minute. I did want to let everybody know, we do have a couple of questions that are pretty specific to, someone's health. And we don't address specific medical questions because these really need to be addressed by your healthcare team that has access to your medical records and understands your history. However, I will do my best to generalize these and get, a general answer for you if Melissa can. But please note that we do our best to answer all of them, but answering really specific ones is a little bit tricky to do without your history and all of that. So let me get started with the questions that we have right now. I wanted to start with this one because I thought this was really interesting. Do you have any idea how many kidney transplants are done annually for PKD specifically? Is that a statistic?
I don't, but I can. Yeah, but I can find out, and because that data is available.
Mm-hmm.
So I'm going to write down this.
So I'm pretty sure that PKD represents about 10% of the chronic kidney disease population. So you would, it's probably not exactly, but that gets us kind of close to thinking about that.
That information is available. It's publicly available, so
okay.
I can do it. I don't know that I can get to it like before the end of this webinar.
Oh, no.
But, I can make
Yeah, I can get it back to the person that asked for it, and we may want to post it or something because this might be something that other people want to know. And another part of that question, do you know what % are living donor versus cadaver donor, deceased donor transplant?
You know what? That is also available, so I'll just add that to the data request.
And we had several questions about getting started with the evaluation. Can you remind us at what point in disease progression can you be referred to the transplant center?
GFR of 25.
Okay. Is that pretty common? Because I know that people have, different centers may refer at different times. And can you self-refer at a GFR of 25?
Yes, and I would. And the worst thing that could happen is they could say, not yet. But normally, especially for PKD patients, there is, there's an understanding that, that your kidney function is declining slowly, and you're trying to get ahead of it. So most centers will accept a referral at 25. If a center doesn't, I would have my GFR done every month, and until it was 24 or 23. Waiting until a GFR is 20 is not considered optimal because it doesn't provide an opportunity for that patient to take advantage of that best case scenario we talked about, which is preemptive, which is getting a living kidney donor prior to dialysis. Now, it's a narrow window, admittedly. It's a, you're trying to balance, okay, your kidney function has to be bad enough to almost be on dialysis and to feel yuck, but it can't be too good. So it's a very narrow window. And so when the GFR starts hanging around 25, I would absolutely self-refer. Yeah.
Okay. And at what point, would you suggest that patients start talking to their nephrologist about, their desire to get a preemptive transplant so that labs can be done frequently enough to be watching that GFR?
There is no time like the present. There is not, any time. I would start now. And this is something that, as a nurse, when I met Risa, and this is something that I learned from her and that I was not aware of, but not all transplant nephrologists or general nephrologists are like willing or enthusiastic about referring their patients for transplant evaluation. And so that was a real shocker for me, honestly. And it just highlighted, though, the need for patients to advocate for themselves. And don't let that stop you. If your general nephrologist is like, well, there's a long time before that. Well, I want you to know, this is what I would say. I want you to know, as my general nephrologist, that I want to be referred as soon as possible, and just reiterate that every single time you see the physician. And so it's not a surprise when you say, okay, we're ready, right? It's time. Ideally, they would be the ones driving that, but I learned from experience that that's not always the case.
Okay. Very good advice. And at what stage is 25% GFR? Is that 4 or 5 of chronic kidney disease?
I believe that's 5.
Okay. All right, so let me scan through here. I think you really addressed this quite a bit, but we do have a couple of questions about, and actually you just did, why is transplant prior to dialysis, so preemptive transplant, particularly important? So I appreciate all the information you've given about that, because we did get that question quite a bit. I don't know if there's anything else you want to say about that right now, or you think we've covered it pretty good?
Yeah, I mean, I would just add that, if you never have to go on dialysis, that's a good thing. It's a good thing to avoid. It's not the foregone conclusion, and it's unfortunate that it's kind of framed that way by the general nephrology community, but it's not a foregone conclusion. And the best case scenario is that you avoid it, because dialysis is really hard on a person's body. It erodes health, vital health. And I think that's often misunderstood or not fully appreciated. So if they're try to avoid dialysis, that's a worthy goal.
Mm-hmm. Okay, so we do have a few people that are Googling the answer. It appears that there are nearly 38,000 kidney transplants performed on PKD patients. This is on the UNOS website, so we'll verify that and put it out when we post this webinar. But thank you for looking that up for us.
Thank you, fact checkers. Yeah.
Yeah.
Those are fact checkers. Yeah.
It's quite quick to get information these days, isn't it? Can you talk a little bit about, we've got a couple of questions about people that have PKD and PLD, so may at some point need a kidney transplant and a liver transplant. Is there value to doing them both at the same time? Why would you do one, kidney transplant and then a liver, or vice versa? What criteria, I guess, would a nephrologist use to determine that? Is that something you could answer for us or address?
I think so. I haven't. Well, I would say the priority, if it's PKD and PLD, which is failing faster, is the priority at which I would give, the transplant. I do not know of a situation where there was a kidney and a liver transplant for PKD. I have for some other things, but not that. Now, that does not mean it doesn't exist, and I can certainly look more into that. But PKD patients have an advantage over almost anybody else that is getting a transplant in that it's chronic, it's not a surprise, usually, and they've had time to plan. And so the kidney liver patient that I'm thinking of had acute failure of multiple organs, and it wasn't a PKD or PLD situation. So I don't know of a situation where they were done simultaneously. I would say prioritize in order of organ failure. And it's definitely something I don't know. Yeah, I just don't know.
Okay. A couple of questions we have about age limits. I think you addressed that pretty well, but maybe just reiterate. We have questions about, is there an upper age limit to receive a kidney transplant? Is there an age limit to be a donor? Is there
that is very,
go ahead.
That's very center specific.
Okay.
And the more aggressive centers will transplant older people up to 75, and there was that one situation of the lady that was 83. But so the more aggressive centers will transplant older patients, but it is very center specific.
Okay. Let's see. I had another question. I can't find it right this moment, but I think I can remember. We had someone asking about, is there a way to predict GFR, your progression? So if you have labs, let's say over the last 10 to 15 years, would your doctor be able to say, I think you're going to hit, 20, 25% of kidney function or GFR of 25 at this time, or you're going to need a transplant by this age? Is that something that can be predictable, I guess?
That's a great question. And I don't know of anything, doesn't mean it doesn't exist, but what a fantastic tool that would be. It would also have to be based on the assumptions that nothing else is going on, yeah. So I don't know of anything, but it's a great idea and we need to develop that.
Yeah, I think that it's probably in general, you could probably get an idea, but that, like you said, there are things that are going to change. So I think that might be a little hard to do, but it would be nice, definitely. There's a couple of questions here about health issues that would disqualify you. So are there certain heart conditions or a little bit about cancer, things like that that would disqualify you from being able to ever receive a kidney transplant? And then on the flip side of that, are there things that would disqualify a donor?
So I'll start with the recipient. There are what I consider to be deal breakers. And the good news is that many of the deal breakers are modifiable. So that would be, drug abuse. I mean, in California, frankly, right now, we're having, the recreational marijuana has kind of changed the scene here. So, and figuring that out, weight, et cetera. The things that automatically rule people out from the beginning are metastatic cancer. And if a person has had metastatic cancer, this is another place that centers vary. But kind of the rule of thumb is 5 years beyond, considered cancer-free. That has some caveats when it comes to like melanoma or skin cancer. But 5 years cancer-free is considered, free and clear. Cardiovascular disease, severe peripheral vascular disease, is one of the things that I see preventing people from moving forward sometimes. And with that, I mean, this is usually the diabetic population, and they have peripheral neuropathies and really bad blood flow to their feet and legs. Like, these are the people who unfortunately end up with amputations. That is a deal breaker. And blood clotting issues. So anything that would swing a person, a hemophiliac, et cetera, like they would bleed too much or they would clot too much. Those are super high risk. So those are some that I can think of right off the top of my head.
Okay, thank you. Here's a really good question. If you have someone that's willing to be your living donor, but not a match for you, can you talk a little bit about paired donation programs? And if you enter into a paired donation program, does that mean that you could potentially get a transplant faster?
Yes, and I could talk a whole nother hour and then some about paired kidney exchange. I think it's a fabulous program. So if you have a donor who is not your blood type, I would highly recommend going into the paired kidney exchange. There are so many benefits to it, and it's a domino effect. And it's hard to explain without drawing a picture or showing a visual, but just understand that it is absolutely in a person's best interest to join the paired kidney exchange if they have a donor that is not a blood type match. Absolutely, yes. And they almost guaranteed to be transplanted quicker.
Okay. Let me see here. Someone says, can there be a paired kidney exchange webinar in the near future? That's a great idea. We'll put it on our planning list.
Yeah. Yeah.
Definitely. There's so many topics, and I'll get to a little bit more about sharing your topic ideas with me when we close this out. So we'll move on for now. What is looked at to determine if a potential living donor is a match to a recipient?
Great question. Blood type and now, size never used to be an issue, and I'm noticing now more we talk about, the body habitus. So, but it's blood type is the primary, and size, if it's an extreme size mismatch, that's a deal breaker. But ABO blood type.
Okay. All right. I'm noticing that it is 8 o'clock, and we do have quite a few more questions. Would you be up for a couple more, or do you, would that be okay?
Sure.
Go over? Okay.
Yes.
Let me just get to a couple more. I won't keep you too much longer.
Sure.
Let's see here. Can you remind us the difference between high risk and increased risk kidneys? If the patient can choose to have these kidneys, what exactly have those kidneys been exposed to?
Great question. High risk kidneys or high risk donors are those who have either participated or been in situations where there's a high risk of a bloodborne pathogen being transmitted. So that includes IV drug abuse, prison, men who have sex with men, sex workers. I think that's it. So that's considered high risk. Increased risk are the category of drug use that does not involve IV drugs. So to give you an example, we used to just classify all IV drug use as high risk. Now it's, well, was there a needle in the arm when the person was found down? It's gotten, it's shifted because there are so many of them. And so that's the difference. The increased risk is considered lower risk, and high risk obviously is considered higher risk. For the increased risk population though, the risk of transmitting disease is less than 0.1%. Yeah, it's very, very, very low.
Okay. And so we've gotten several questions about the donor and the recipient, like does height matter? Does male versus female matter? Does age matter? Is there an age range between the donor and the recipient that would, disqualify that person from being able to donate? Can you address that a little bit?
What we try to do, yeah, of course. Male, female, it doesn't matter. The blood type matters, and the body habitus, the height, et cetera, is only a factor in extreme cases. And when I say extreme, I mean, usually it has to do with a pediatric case, an adult going into a pediatric. That's kind of the extreme I'm talking about. Now, the age difference is something that we consider. So for instance, if there is an 18-year-old that needs a kidney and his 60-year-old grandfather wants to donate to him, we say, wow, that's awesome. But in those situations, we would want to give the 18-year-old or match him with a better or more, more closer to his age donor. So we would, this is where the paired exchange is so valuable, because we could look for pairs that where the donor is closer to 18 and not 60, and the recipient, does that make sense? Where there's a better age. So that's kind of the bonus to the paired exchange, is that we can better match patients to age, but male female is not an issue at all.
Okay. So I think there's two more topics that I'd really like to address right quick. One is, can you talk about the costs that are covered by the recipient for the donor?
Great question.
Surgery, travel.
Yep. Oh, okay. Well, all of the medical costs are covered or should be covered by the insurance company or the center through Medicare. So that should not be an issue. Travel is not included in that. So if somebody is flying across the country to donate, that expense is not normally covered. Now there's a national organization called the National Living Donor Association, I believe, and they have money to support situations like this. So there are dollars out there, but you have to request them. So it really also depends on the payer. So if insurer X might cover, travel expenses, lodging, food, and et cetera, but another payer, this is private payers, may not pay for anything like that, just beyond the actual surgery and post-nephrectomy care. So it's very provider dependent. Medicare does not routinely cover anything travel related.
Okay. So these are really good questions to go over with the financial coordinator when you're at the transplant center. So the last thing that I think,
definitely.
Yes, definitely. The last thing that I wanted to see if you could address for us is the cost of medication. So we have several questions about, anti-rejection medications, post-transplant. One person was talking about how that may change after transplant. So you mentioned, you have to have labs done and they tweak your medications, and that can mean that your medications may cost different, than what you may have been expecting from what they originally told you. And also, let's see, I think there was one more. Well, maybe just the cost of medications in general. So how do people know, first of all, how much they're going to need to be able to spend to cover the cost of their medications? And just talk a little bit about why medications may change a little bit after transplant.
So there are two medications that are usually the most expensive. The first is the immunosuppressant, and this is the medication that's given to patients so that their immune system doesn't recognize the new kidney as an enemy and attack it. So this has a very narrow therapeutic range, and we, as a community, have not figured out what some patients require a lot more of the medication to reach that therapeutic range. Some patients require much less, but that's the variation, and that's why those labs are drawn so frequently. It's checking to see if that medication level is in that therapeutic range. So that's why there's variation. So an example would be, a person was initially prescribed 5 milligrams in the morning and 5 milligrams at night. And afterward, they realized that was too much. So they go down to 4, or they could realize that was too little, and they could up it to 6 or 7 or 8 twice a day. So the variation is directly related to trying to keep it in that therapeutic range. The second, though, is the antiviral. And antivirals are expensive medications. This is ganciclovir, acyclovir, anything that ends in VIR. And usually, unless there is a compelling reason otherwise, patients are only on that for the first 6 months, and then they don't have to take it after that. But there are situations where if a person received a CMV, which is cytomegalovirus positive kidney, then they'll need to take it longer. So those are the two that are usually most problematic. Now, how do you know how much they're going to cost? This is where the transplant financial coordinator is so important. And I can only speak for the 2 centers where I was in charge of this, but we had worksheets that must be completed by each potential recipient. And it breaks down the cost, and we start at 10 milligrams. Just assume that it's 10 milligrams of Prograf, which is a high dose. But we want to prepare patients for, the reality of what's going to happen. And so all of that is provided on a worksheet, and so there is an estimate of what the monthly costs will be. Now, the wild card, if you will, is the insurance coverage, and all of the payers are different. And so I can't really speak to that specific.
Okay, we lost you just for a second there. I don't know if everyone can still hear me. Hopefully they can. Melissa, are you there? Can you? I'm hearing typing, but I'm not hearing Melissa. Okay, if she comes back, we can speak to her again, but we are over time, and I just want to thank everyone, our attendees and Melissa, for staying over time with us. It's just amazing information, and there's so many takeaways that I got from this. So thank you very much. Wait a minute, I'm getting, okay. So that is all the time we have tonight. Many thanks to Melissa for answering our questions and for all the information that she's provided. I know and feel confident that we all have a better understanding of how transplant centers work and what to expect when it's time to consider a kidney transplant. The PKD Foundation appreciates the opportunity to provide you with the best possible education. After the webinar, you will receive a brief survey. We appreciate your feedback, and we will use your responses as we develop additional resources and programs for the future. When you complete the survey, please make sure to include additional topics that you would like for us to address in future webinars, and we will add that to our webinar and resources planning. If you need to reach out to us directly, please email us at pkdconnect@pkdcure.org, and a member of our PKD Connect team will get back to you. On behalf of everyone at the PKD Foundation, we wish you a lovely evening. Thanks so much, everyone. Good night.